Welcome to Conversations on Healthcare. This week we welcome Dr. Rachel Levine, Assistant Secretary at HHS, on the Biden administration's efforts to address long COVID, child vaccine uptake, women's reproductive health, and monkeypox. Now, here are your hosts, Mark Maselli and Margaret Flinter.
Our guest leads an office that just reported an estimated 7 to 23 million Americans have developed long COVID. Research has shown a long COVID condition can last weeks or months, affecting all ages, backgrounds, and demographics. Previously healthy individuals may become disabled while others heal.
Here to discuss this issue and other timely topics is Admiral Rachel Levine, Assistant Secretary for Health in the U.S. Department of Health and Human Services. She's connected to the researchers who are working quickly to better understand long COVID, which is a multi-systemic and multifaceted disease.
Well, Admiral,
thank you very much. I'm very pleased to be here.
Yeah, we're so glad that you're back joining us on Conversations in Healthcare. And you were last with us in June of 2021. And at that time, we talked about the health equity and mental health issues related to COVID. Now, of course, the Biden administration just released the National Research Action Plan on long COVID, and it's the first U.S. government-wide national research agenda focused in on this issue. Some clinicians say that patients with long COVID are either unvaccinated or missing their boosters. Are you seeing that in the work so far?
Well, so we are seeing that vaccination is somewhat protective for people in terms of getting long COVID. But we need more research, and that's what the National Research Action Plan in that report emphasizes, is that we have done research through the NIH and CDC and other departments, but we need more research, and the plan outlines the research to come.
Well, Admiral, there's another report out now that outlines federal services that are available to Americans to address long COVID. And it includes resources for healthcare personnel who are treating patients with long COVID, which is certainly a challenge that's emerging for healthcare personnel in the U.S. What are the unique risks for patients with long COVID? And for their healthcare providers, is it significantly different from treating what we might call the initial stage COVID patients?
Well, we still have more to learn about all of the different aspects of quote unquote long COVID. There are many different signs and symptoms to long COVID. And that is really the point of the research action plan through the NIH and the CDC and others. But you're right, we have a second report, the Services and Supports for Longer Term Impacts of COVID-19. And this outlines the federally funded supports and services for individuals and families experiencing those longer term impacts. And it also does outline recommendations for physicians and medical providers that are seeing those patients. We don't know exactly what is causing long COVID. It might not be one thing, but long COVID is real, and those patients need support and they need treatment. The treatment can't be as specific as one medication or one specific treatment, but they do need support, as we do for many other patients with these type of chronic conditions.
Well, I think you're so right that we need more research, and not only with NIH, but others, as you indicated, are doing that. And we read recently in a science magazine that others have suggested that long COVID might actually be a post-infection syndrome, and that may highlight there are no autoimmune markers to make, quote, a real disease. I wonder if you can address that perspective.
Sure. Well, again, I want to emphasize that long COVID is real because we want to emphasize that patients are not malingering. But we don't know exactly, as I said, what causes long COVID. So there are some research studies that indicate that it might be a chronic infection with COVID-19. And there was a recent research study from Harvard a month or so ago which suggested that. But we need much more research to know if it is a chronic infection or whether it is more of a chronic inflammatory response, as you said, a post-infectious process. In my field of adolescent medicine and my academic medicine career, I saw many, many teenagers and young adults with post-infectious symptoms. So whether that was patients with neuromediated hypotension and postural tachycardia and a tendency to faint associated with other behavioral aspects, whether it was patients with chronic abdominal pain after probable viral gastrointestinal infections. This is not new to us. This is not new to medicine. The one syndrome that we have seen is ME/CFS, myalgic encephalitis with chronic fatigue syndrome, and we've been studying that for years. What we're hoping for is that the research into long COVID will also give us new perspectives on those illnesses as well.
Well, Admiral, the sheer numbers of people infected and within a relatively short time in our country hopefully is bringing tremendous focus on this, and we really thank you for your leadership efforts in this area. There is so much going on in our country right now. I'd like to ask you about another front. We're still assessing the impact of the Supreme Court Dobbs decision overturning a constitutional right to abortion. President Biden has just praised Kansas voters for rejecting an abortion ban, and the Justice Department's filed a lawsuit against Idaho to block a state law that would allow doctors to be criminally prosecuted for providing abortions. And the president's signing an executive order aimed at supporting Americans who cross state borders for abortions. In terms of access to reproductive health care, including abortions, can you comment on what more needs to be done, and can we expect to see further actions in the near future?
Sure. Well, this is a critical issue for the Biden-Harris administration and for Secretary Becerra and myself and others working at HHS. Access to health care, access to reproductive health care and reproductive rights is a core value of the administration, really across the federal government, and particularly for Secretary Becerra and HHS. So the Secretary has laid out a plan and is working to take action to help people. And as you said, the President signed an executive order today. So, we want to make sure that we protect patients and providers from discrimination. We want to protect emergency access to abortion care. We want to make sure that providers have training in these services, and we want to strengthen family planning care and emergency contraception in the face of this extremely difficult and challenging Supreme Court decision. And so we are working through my office of the Assistant Secretary for Health, and then other offices, our Office of Civil Rights and others, on these initiatives. We have launched a website, reproductiverights.gov, which is a public awareness website. We are convening health insurers and calling on them to commit to meeting their obligations to providing coverage for contraceptive services at no cost, which is required by the Affordable Care Act. There is new funding to bolster training and technical assistance for Title X planning providers and more. So many different efforts across our department and the administration on this issue.
Admiral, let's just stay on that topic for a moment. The administration has issued guidance to remind health plans and insurers of the Affordable Care Act's contraceptive coverage. In light of the Dobbs decision, a group of senators has asked the Veterans Affairs Secretary to provide abortion access to veterans in states that restrict or ban the procedure. Would you be in favor of such a move?
Well, that's more of a legal issue that for the VA that I can't really count on. But we want to make sure that people have access to the reproductive services that they need and they deserve. And so we'll be working across the department and administration to achieve that.
And Admiral, yet another major public health threat now in everyone's consciousness. I think across the United States, we're dealing with monkeypox. And we'd like to give you a chance maybe to respond to critics, some in the LGBTQ community included, who say that the Biden administration has not done enough maybe to prepare as well as to respond based on what is happening now. Certainly, we are seeing overwhelming interest in receiving the vaccine by the targeted populations. at risk at our community health centers here in Connecticut, but the supply is low. We don't know whether it will be able to be replenished. Can you comment on this for us?
Sure. Well, the monkeypox infection issue is a critical issue for the Secretary and for HHS, and obviously for the administration. They have just hired a coordinator at the White House and a deputy coordinator with Dr. Daskalakis, who has been in the New York Health Department and the CDC, very experienced in terms of these infectious disease issues. And so we at HHS look forward to working with him. You know, remember that the supply that we have had in the national stockpile has been for potential smallpox infection. There's no way to have anticipated that monkeypox would have spread the way it has in the world and in the United States. So we are fortunate that we have had a supply of the Jynneos vaccine that we have distributed to the state health departments for administration. And we are working with the manufacturer, which is located overseas, on purchasing more. We have received much of that vaccine and are working on distributing that. And then we've purchased more for the future. The CDC has outlined a procedure for the distribution of the vaccine, looking where the infections are now, but also looking to where they anticipate the infections will be in the future, so that we can stay ahead of this. So we want to use all the tools in our toolbox. We have expanded testing, and we have expanded testing to commercial laboratories. So testing should be much more available now. There are 5 commercial laboratories that can do testing. We want to work on mitigation and ways that people can help protect themselves from infection with monkeypox, which is different than COVID-19. It is spread only through close personal contact. It's not going to be spread across the room the way that COVID-19 can be as a respiratory virus. And we're working on distribution of TPOXX, which is the treatment. Now, again, the treatment was designed for smallpox, not for monkeypox, but it is effective against monkeypox. And so we want to work on the distribution of these resources, which, again, the vaccine and the treatment have been stored for potential smallpox infection, but we are deploying them for the monkeypox response. There is another vaccine that people have mentioned, the ACAM2000 vaccine, that also does have significant stores in the national stockpile for any potential smallpox infection, but it's a different vaccine. It's a live virus vaccine that is not totally attenuated, and it does cause a viremia, an active infection in people who then usually pretty mild, who then mount this effective immune response. But for people who are immunosuppressed, it can lead to a severe active infection, and it also can be spread by someone who's been immunized and could have spread to a close contact who might be immunosuppressed. So, you know, in the community most impacted, the men who have sex with men community, and the potential of HIV in that community, the ACAM2000 is not really an effective countermeasure at this time. You know, we want to make sure that we deal with any issues of stigma associated with monkeypox. Anyone can get monkeypox. It just has started and spread in the men who have sex with men community, and that's where we've been targeting our resources right now.
Well, that was some very important information on monkeypox, and I know we're going to have some more questions about it, but I do want to highlight that the percentage of Americans without health insurance hit a record low 8% in the first quarter of 2022. But maintaining that low rate depends on a lot of factors, whether the Senate can extend expanded Obamacare subsidies through the reconciliation bill. And as we talk with you, it's really unclear if Senator Sinema will cast the crucial Democratic vote needed to make this happen. If the senator were listening right now, what would you say to her?
Well, you know, so it's not for me to, as the Assistant Secretary for Health, to give any of the senators personal advice about their vote. All I can say is that it is critically important that we continue that positive trend and continue to work on decreasing as much as possible the uninsured rate in our country. So measures that help decrease the uninsured rate are very important for medical reasons and for public health reasons.
I'm wondering if I could do a follow-up, because another big issue that's is the emergency order that the president still, I think, has extended until October, which for all the 50 states and territories means that I believe there's no sort of redetermination going on in Medicaid, and that once the emergency order is lifted, there may be an enormous number of people who lose their Medicaid coverage. Any thoughts of ways that that can be mitigated? And again, there's a 90-day promise back to the states that will let you know before we take this action. But still, millions of people in the balance here. What are your thoughts?
Well, I know that this is a very important issue. And I know that Chiquita Brooks-LaSure, the administrator of CMS, and the secretary and others are looking at this very, very closely, because it is very important.
Well, Admiral, we've been at this for a long time. We certainly remember the pre-Affordable Care Act days, and hope the positive trends that were wrought by it continue. And we're also very proud of the work that our community health center is providing in terms of providing exceptional care and sensitive care to our LGBT community, and this includes gender-affirming hormone therapy. You were part of a recent roundtable of families who have children who are transgender. Maybe you could share with us a little bit about what you heard about what people need, what might help more Americans understand what's at stake here. Certainly, the vitriol from the anti-trans forces is very worrisome right now, particularly when we think of our young people.
So you are correct. We've made so much progress under the previous Obama administration and in President Biden's administration for the LGBTQI plus community. But unfortunately, we are facing a significant politically motivated backlash, where there are politicians, particularly in states, that are enacting laws and taking actions that are politically motivated and very challenging and potentially damaging to vulnerable LGBTQI plus youth, particularly for transgender youth and for gender diverse youth. So we're talking about actions in Texas and actions and laws in Florida and in Alabama and in many other states. So we're going to need to respond to these challenges, because we want to affirm young people in general. We want to empower young people, but we also want to affirm and empower young people who are transgender and help them in their care. So these actions that limit their participation in sports and activities, actions and laws that actually limit their ability to access gender affirming treatment, often by pediatric specialists at our expert children's hospitals, are egregious. And so we're going to respond in a number of different ways. One is in terms of advocacy. So the president has spoken about this, the vice president, the secretary, myself. As you said, I have visited with young people throughout the country at gender affirming clinics, whether that's Seattle Children's Hospital, Children's National Medical Center in Columbus, Ohio, and DC Children's at Children's National Medical Center, and many other places. I've heard from these young people. I've heard from these families about the challenges that they're facing. So I have gone to Texas. I have gone to Florida, and I am speaking out about this. But that advocacy is necessary, but it's not sufficient. So we're also working on policy. In the last number of weeks, our Office of Civil Rights has put out for public comment their rule and regulation, which states that the Affordable Care Act and Section 1557, which states that you cannot discriminate on the basis of sex, that includes sexual and gender minorities, that includes sexual orientation and gender identity. And after the public comment and those rules are promulgated, that will inform everything that how we look at that issue across HHS, including for HRSA and community health centers, including for CMS and for Medicare and Medicaid and for insurance coverage. And so we're looking forward to the promulgation of that regulation. I know that in other departments, at the Department of Education, they have made the same interpretation for Title IX, and that has gone out for public comment. And we know that the administration is going to be working on the legal front with the Department of Justice, which has already weighed in with a brief and comment on Alabama's law, which actually made providing gender affirmation treatment a felony for those pediatricians and experts at children's hospitals. And then finally, the president has called for Congress to pass the Equality Act in terms of rights and for sexual and gender minorities. So we have to work on all of these fronts to protect the rights and freedoms for LGBTQA plus individuals and their families.
Well, it is so important to focus on rules, regulations, and legislation. There's a lot that looks like it's in the pipeline that will have a profound impact. But I do want to just note for our audience that you're known and praised for your mental health work. So thank you. And certainly it was good news when the new 988 suicide and crisis hotline began. And there's a federal mandate and $430 million allocated to states to expand their crisis networks. But now there are reports that there are 29 states have not introduced any legislation to address the 988 hotline funding. What can the administration do, and can they work around the states and maybe directly fund nonprofits to do this work? What are your thoughts?
Well, so you're correct. Mental health challenges coming with the pandemic have been very serious, particularly for youth, but really across the lifespan. And that includes, of course, the disease of addiction and substance use. But we have had a lot of concerns about suicidal risk among specific communities, particularly young people. Also, we were talking about the LGBTQI plus community, but other communities that have been very impacted by the COVID-19 pandemic, the African-American community, the Hispanic community and Latino community, the American Indian, Native Alaskan community, and more. And so last month, with my associate, Assistant Secretary Delphin Rittman of SAMHSA, HHS launched a new 3-digit hotline, 988. It is for calling, but it is also for texting and chat. As I'm sure you know, teenagers don't call. They will use texting, or they might use chatting. And using that 3-digit line, they will be connected to trained counselors, part of the existing National Suicide Prevention Lifeline Network. And so we are continuing to work on all of these different aspects. There has been $432 million, including $105 million in grant funding to states and territories provided by the American Rescue Plan. We're working to work with states and territories on the implementation of this plan. So this is being done, again, primarily through my colleague at Dr. Delphin Rittman at SAMHSA, and they're going to try to work with all of the states and all the territories to make sure that this critically important lifeline is implemented.
Well, Dr. Levine, Admiral Levine, we really want to thank you for joining us, for your willingness to comment on such a wide range of issues of great concern and interest to our country right now. It's especially meaningful to us as the week of August 7th is National Community Health Center Week, and we appreciate your understanding and appreciation of the work that community health centers do and how vital healthcare as a right for people in our country is. And thanks also to our audience for joining us today. And you can learn more about Conversations on Healthcare and sign up for our emails at www.chcradio.com. Admiral Levine, thank you so much again for joining us.
Thank you. It was a pleasure.
Great. Thank you so much for the great work, and so much exciting work is going on. Appreciate you and all of your colleagues.
Take care now.
Bye-bye.
Bye.